Welcome to the Population Health Management Podcast, brought to you by Lightbeam Health Solutions. My name is John Henson, and I'll be your host for today's episode. So we have Maha Salah-Ud-Din. Maha is a Lightbeam Advisor with Lightbeam Health Solutions. And our topic today, we're going to be talking about chronic care management. So to start off, Maha, can you just kind of give us a little bit of background about who you are, kind of what you do, what your role is at Lightbeam?
Sure. So as you alluded to, I'm an advisor here at Lightbeam. I've been with Lightbeam for almost 2 years now. And as an advisor, what I do is I work with our clients to really make sure that they're using the application in a way that meets their business goals and objectives. And additionally, I help them identify additional programs or reporting needs that they might have that they just need assistance with.
Awesome. So, like I said, the topic today is chronic care management, and we decided to bring you in because you have a ton of experience working with our clients, implementing their programs, their CCM programs. So, the way that we're going to try to structure this is we're going to talk from a strategy perspective, how CCM plays into overall population health management and value-based healthcare, and then we're going to try to break it down to more of a tactical level, kind of how do you actually implement the program, what type of resources can you leverage, and so on. So I guess to start, why is CCM so important? Kind of what is it, if you kind of start there?
Yeah, so CCM is chronic care management. It is a Medicare reimbursed program, and it's for those patients that have 2 or more chronic conditions. And the reason that we really care about these patients is just because the burden of chronic disease is increasing as time progresses. So Medicare patients who have 2 or more chronic conditions actually account for almost 93% of overall Medicare spend. And so these patients that have 2 or more chronic conditions, they also have higher levels of hospitalization, pharmacy utilization, and specialty utilization. And as I mentioned, CCM is a reimbursable Medicare program. It is 20 minutes of non-face-to-face interaction with the patient per calendar month. And on average, the reimbursement is about $43. That does vary based on a region. So, Central Texas and Eastern Texas might have different reimbursement rates. And if you have specific questions for your area, just let me know. We can kind of help with that. In terms of patient eligibility, like I mentioned, the patient just has to have 2 or more chronic conditions that are expected to last at least 12 months or until the death of the patient. And examples of some of these chronic conditions is cardiovascular disease, depression, diabetes, hypertension, COPD. So definitely conditions that we see throughout the Medicare population. And really the benefit is that a lot of practices are already managing these patients. So this is kind of CMS sending them a little note that says, hey, now we're going to start really paying you for the work that you've already been doing all this time.
As we kind of get into the discussion of value-based healthcare, being reimbursed for the value of care that you provide, could you kind of explain just a little bit about some of the benefits with implementing CCM? Obviously, 93% of total Medicare spending is a huge number. So kind of how does it fit into helping our clients or helping healthcare organizations achieve the triple aim, quote unquote?
Yeah, so for the patient, really what they have is they have a care team that is 100% focused on them. So from the patient's point of view, they have someone who's going to contact them at least, minimum once a month and talk to them about their health conditions. They're going to teach them techniques and ways that they can do self-management of the diseases. It helps alleviate the onset and the disease burden for the patient. So it's going to hopefully alleviate any worsening of the disease. From the provider standpoint, the provider is now highly engaged with the patient who's high risk, who has a higher risk of hospitalizations, pharmacy utilization.
So let's transition into kind of more of the tactical side. What are some of the common barriers to getting a CCM program up and running for an organization?
Yeah, so the barriers occur on both the side of the practice and the patient. So from the practice viewpoint, staff might be a big barrier, right? So you might not have the staff in place to be able to call 50 or 100 patients every month. The staff maybe would rather focus on, seeing patients in the office. So that's definitely a limitation. Technology is usually a big limitation as well. So one of the requirements for CCM is 24/7 access to phone and secure email, i.e. a patient portal. So some of the practices that are, maybe still on paper, who can't, electronically share a care plan with the patient, they're not able to implement CCM. Or someone who might not have, again, the staff to be able to provide 24/7 access, they might not be able to implement CCM. From the patient perspective, the copay is usually a barrier. So usually it's about an $8 to $10 copay for the patient every month. So that might be a barrier. It is covered by supplemental insurance. So if the patient has an additional insurance from a commercial insurer, they might pick it up. Other barriers for the patient might just be the burden of the phone calls. So sometimes the patient might just not want someone to call them, a couple times a month to check in on them. It might be a barrier. We found sometimes that also just the demographic information, so not having the most up-to-date phone number in the EMR, not having a valid phone number, is usually a barrier for practices. So I say if you're starting off, make sure you have the right patient information and it's documented correctly in your EMR.
So no, you mentioned that getting the patients on board tends to be a little bit of a difficult conversation. So if you were, I guess, in the shoes of the clinicians, how would you frame that type of conversation with a potential patient who's eligible to enroll within CCM? What would that conversation look like?
Yeah, so in order to start CCM, you actually have to have verbal consent from the patient that they would like to enroll in CCM. And the best way to really get this consent is when the patient's already in your office and you're already seeing them for some E&M code that the patient's coming in for. So we always recommend initiating the conversation during an annual wellness visit or an office visit that's already scheduled for the patient. And at that time, make sure that it's the provider that is actually talking about the program and the benefit with the patient. So they really know that, hey, my provider feels like they're able to provide better care and I'm better able to manage my health if I enroll in CCM. So definitely get the consent during a visit that the patient's already in for. Don't have the discussion once the patient has been discharged from the hospital. It can be really overwhelming for the patient when they're having home health already in, or they're having, maybe a nurse already called them for transitional care management. So it can just be really overwhelming for the patient to have multiple people checking in on them.
And from a billing perspective, what are some best practices around optimizing the way that you bill for CCM?
So there are certain exclusions with billing CCM. So you actually cannot bill CCM if you're already billing transitional care management. So transitional care management is going to be for those patients who had a recent hospital discharge and you're helping move them to SNF or home. You cannot bill CCM if home health care and hospice are already being provided. And then additionally, if dialysis and end-stage renal disease services, so ESRD services in particular, are being rendered, you cannot bill CCM. Additionally, there is a second CPT code, which is the 99487, that's complex chronic care management. And CCM and complex care management cannot be billed at the same time.
Awesome. So we've talked about, how CCM fits into an overall pop health strategy, and then we talked a little bit about some of the tactics with framing the conversation with your provider patient relationship and also with billing. So obviously there's a big incentive that CMS has been pushing to the providers to implement CCM within their organizational workflow. I guess the question is, has there been any concrete research that you've seen come out, or any case studies maybe that you've seen, or any real examples where you've seen real success while implementing CCM?
Yeah, so it does take time for CCM to kind of have an impact. So, don't expect to reach out to a patient once a month and then expect that patient to result in, thousands of dollars of savings for the practice. So it does take time. Studies have actually shown there's an observed increase in spend in the first 6 months, just from the patient learning self-management techniques, maybe switching medications, maybe making more office visits just to make sure that they're all caught up on all their preventive exams. But then there's a decrease of $32 in the 12 months following, and 18 months out, there's a $74 per member per month decrease in spend. So it does take time if you stick with it. And additionally, we've seen a decrease in hospitalizations, a decrease in SNF usage, a decrease in overall ED utilization. And what's really good for, I think, a lot of practices who want to start CCM is that despite the barriers, the use of CCM has increased over time. And what's most interesting is that the patients who originally sign up for CCM, they continue and they stay with the program despite the barriers like the copay. So obviously there's financial benefits for the provider, but there's also numerous benefits in terms of just better managing your health that patients are seeing just because they're sticking with the program.
So for the organizations that are going to basically start to implement their CCM program, there's going to be a little bit of disruption within the native, within their workflows. So if you could talk about what some of those elements are of how to get a CCM program up and running, I think that'd be helpful.
Yeah, and I alluded to some of this earlier. So the first is, structured recording of patient health information. So you have to have some platform that you're able to document the care plan, patient demographics, health problems, medications. For providers, this is going to be their EMR. So unfortunately, if you are a practice that's still on paper, you're not going to be able to provide CCM services since this is a requirement. So must have a certified EHR, be able to record patient demographics, health problems, medications, allergies. Use this information to develop a care plan. So that's kind of the next step. You have to develop a care plan. The care plan is going to touch on the problem list for the patient. So this is going to include the chronic conditions that got them enrolled in CCM in the first place. So this could be patient has diabetes and cardiovascular disease. Any expected outcomes and goals you have. So if the patient does consent, you sign up, you start building the care plan, set a goal in place. Okay, 6 months from now, she wants to be able to, go on vacation with her kids, and she wants to wean off insulin, whatever the goal might be. Talk about symptom management. So in this case, we're going to talk about, okay, Mrs. Smith, if you do have an onset of COPD, what's the next step? What are you going to do? Are you taking the right inhaler? Do you know where the closest urgent care is? Same thing, kind of talk about an intervention and have a plan in place for if something does come up, what's the next step that they're going to do. Medication management and reconciliation. So this is a big one. You want to make sure that the patient is aware of all medications that they're on. Definitely have like their little medicine bag kind of ready to go when you're on the phone with them, so they can kind of walk you through, here's everything that I'm taking, from vitamins to my cholesterol medication to my heart medication. Make sure you have some sort of community or social services in place. So a lot of times you might get on the phone with the patient and discover that the patient has access issues, that they're not able to see their provider, or maybe the patient has food insecurity, so you really need to reach out to a food bank or something else that will help the patient kind of get the resources they need. Next is just enhanced access to care. So like I mentioned earlier, you obviously have to have an EHR, but you also have to have 24/7 access to the physician. So this could be either via portal or like a helpline that the provider has. So the ability for the patient to communicate with the practitioner has to be there. And again, like I said, this can be there via telephone, secure messaging, email, or even the option to do face-to-face. The other step here is just comprehensive care management. So this is really more than just basic care management. It's in a full evaluation of the patient's medical, functional, and psychosocial needs. So like I touched on earlier, if you need to, doing a home evaluation to make sure that the patient is not at a fall risk, doing a full evaluation of, okay, who are the people that you live with who, that can help out. If you have a food insecurity, let us know. If you have access issues, let us know. The last is managing transitions between healthcare settings. So if the patient is discharged from a hospital, you need to be aware of that. You as the chronic care management professional need to be aware of that. And you need to be able to update the care plan and then share it with any providers that are involved in the patient's care. So if the patient's cardiologist is involved or their PCP is involved, that care plan does need to be updated and shared with that individual.
Okay, so the 5 elements that you just described, elements of CCM, are structured recording of patient health information, having a comprehensive care plan, having access to care and care continuity, having comprehensive care management, and having transitional care management.
Correct.
So I know a major part of being able to bill for CCM is capturing that 20 minutes with the patient per month. Can you talk a little bit about what qualifies as actual CCM time with the patient?
Yeah, so you are correct. It's 20 minutes of non-face-to-face time. So this can be reviewing x-rays and labs for the patient, arranging for referrals, speaking to home health care nurses if the patient's on home health or is transitioning, sending the care plan to the specialist, updating the care plan, all of these count, answering patient phone calls, emails about chronic conditions, or if the patient has questions on, their medication usage or certain preventive services that they want to sign up for, all that time counts. Additionally, it's not just what time, but also whose time counts. So all members of the clinical team, so this includes the doctors, the NPs, the PAs, the nurses, any clinical office assistants, their time counts. So as long as any of those members of the care team are touching base with the patient for at least 20 minutes every month, that time counts. Clerical time does not count. So if your receptionist is picking up the phone and transferring it to, the RN, that time does not count.
Okay, so if some of our listeners were interested in getting some more information on how CCM works, kind of more deeper dive into the requirements, where would you suggest they go to find additional resources?
So CMS.gov is always a good place to start. CMS has a lot of information on just the requirements, the exclusions, who qualifies, the providers that can provide the care. So that's definitely a good place to start. Lightbeam also has a blog that we did on getting patient buy-in for CCM. So that kind of walks you through a lot of what I discussed today in terms of requirements, but also talks about patient buy-in and how to get the patient on board.
Excellent. So I can provide a link to both those resources here below. Well, Maha, I really appreciate you joining us today. I think that you provided a lot of really good information on chronic care management, and we do appreciate you joining.
Thanks for having me on.